Now let's talk about the treatment management, and before this let's see the tests done, okay, and the percentage of that which comes positive, the percentage of patients with abnormal tests results, okay. So brain MRI, there is abnormal figure in like 70 to 90% of the cases. Then we can go for like somatosensory evoked potential, which is positive in like 50% of cases. Then we can go for VER, that is visual evoked response, that is positive at almost like 50 to 90%. Then we can go for brainstem auditory evoked responses, so that is positive in 20 to 55%. Then we can also go for CSF IgG index, which is positive in like 75%, and also for CSF oligoclonal banding, that is positive in 85 to 95%. Highly specific. Yeah. And brain MRI is obviously highly sensitive. Yeah, we also go here for stem cell transplant for a better prognosis. Okay, we'll discuss it further now let's venture into the treatment and management. So first we'll mention the drugs which are used, then I'll tell you in details. Okay, let's see. Let's change the color. Okay, the drugs are like follows. These are glatiramar acetate, dimethyl fumarate, fingolimod, interferon beta preparations. Very important drugs. That's why I'm going very slowly. Natalizumab, okay, metoxantrone are some of the like very primary disease modifying therapies, DMTs. Very important. Okay, in this many drug have like very bigger side effects, like this fingolimod is like cardiotoxic and things like that. Then natalizumab is also a great drug, what we have discussed, but yeah, it also carries like a lot of side effects. But yeah, that we'll discuss. For the part being, we are just continuing it. So immediate treatment initiation upon diagnosis is crucial for multiple sclerosis. As the progression, it is a progressive disease, so better to manage before many symptoms can occur. So the short term goal focuses on decreasing MRI lesion activity, while long term goal aim to prevent secondary progressive multiple sclerosis, right? So the post treatment challenges. What are the post treatment challenges? That includes the ensure patient compliance and monitoring for drug toxicity. Very important. As I have told, these drugs have a number of side effects. So monitoring the drug for the overdoses is very necessary. So in the realm of treatment and management for multiple sclerosis, several DMTs, as mentioned below, offer various mechanisms to address the underlying pathology. So now we are going in details. Okay, let's see about the glatiramar acetate. So this is a synthetic polypeptide mixture that may act as a ligand for like major histocompatibility complex molecules, limiting their activation and promoting regulatory cell induction. Okay, this drug may also have some neuroprotective and repair mechanisms. This glatiramar acetate is administered subcutaneously. Okay, the patient can administer it by themselves and is generally well tolerated. However, the drug is ineffective for progressive forms of multiple sclerosis. Got it? Now, interferon beta preparations. So these are the preparations which were used, now they have like modest results. Okay, so these preparations act through like multiple mechanisms, including the modulation of T and B cell function, cytokine expression alteration, and the potential role in blood-brain barrier recovery. Okay, and the reduction in the matrix metalloproteinase expression. This also can be administered self, either by IM or SC route, and they may cause like flu-like symptoms and possibly briefly worsen the patient neurological symptoms, but yeah, overall result in a better prognosis, but it is not commonly used nowadays. So natalizumab, very important drug which we have discussed. So this drug is administered IV, and it is a humanized monoclonal antibody which blocks the leukocyte adhesion to vascular endothelial cells, thereby inhibiting leukocyte migration into the CNS. Okay, although generally well tolerated, natalizumab may cause mild headache, flushing may occur during IV administration. So we administered it slowly. Okay, now let's see this metoxantrone. So this is also an IV administered chemotherapeutic agent. used to treat multiple sclerosis and due to its effect on DNA repair and RNA synthesis. Okay. A possible effect on cellular and humoral immunity, that is T and B cell, represent the therapy mechanism for multiple sclerosis. However, it is limited in use due to the various adverse side effects which has been documented, including amenorrhea. Yeah, this drug causes like amenorrhea in the patient. They never develop period in their whole lifetime. So this is a very dangerous drug, and alopecia for like cosmetic purposes. But yeah, amenorrhea is like literally dangerous. Okay, that will make the female fertile for life. So let's venture into this very important drug, that is fingolimod. So this is an orally administered drug, very important, like orally administered drug. Okay, and it is have an immunomodulatory effects, possibly relating to the inhibition of T cell migration. However, possible adverse effects include lymphopenia, bradycardia, hepatotoxicity, thereby necessitating careful monitoring. Patients with secondary progressive relapsing, and the primary progressive multiple sclerosis primary experience neurodegenerative processes. Okay. Due to this, DMTs show varying effectiveness ranging from possible benefits to limited impact due to disease progression. So typically younger patients with shorter duration of progression tend to benefit more in this therapy, obviously. Now let's see the guidelines and principles for acute relapsing management. Okay, guiding principles. So there are like several guide the treatment of acute relapses in multiple sclerosis, that includes like addressing possible underlying process that could have triggered a relapse, such as an infection or metabolic derangement. Then providing symptomatic treatment based on specific neurological symptoms. Okay, then administrating a short course of corticosteroids to assist in recovery, then implementing rehabilitation program involving physical and occupational therapy for comprehensive management. Okay, women of childbearing age should avoid certain medication due to potential risk. Yeah, there is a famous quote about this multiple sclerosis, that overall in females who are pregnant, they tend to have like decreased progression in multiple sclerosis, but in the first 3 months there is increased progression. So overall there is decreased risk or decreased progression, but in the first trimester there is like increased progression. Okay, whatever. Let's see. So teratogens, which are teriflunomide, cladribine, then siponimod, fingolimod, ozanimod, these drugs have like higher risk of teratogenicity. So, and drugs which are higher risk of rebound symptoms upon discontinuation are fingolimod, siponimod, natalizumab, and ozanimod. Okay, now the treatment of acute exacerbation of multiple sclerosis. So the neurological symptoms may include increased disability, increased impairment in strength, cerebellar function, vision, significant sensory disturbances. So like we can give steroids, either IV or oral, whatever tolerated, prescribed by the physician and described. IV methylprednisolone administered at a 3 to 7 day course from 500 to 1000 milligram daily, optionally followed by a short prednisolone tapering. We taper the dose. We taper it. Obviously, you know this now, right? And in oral prednisolone case, it can be administered at a dose of 1250 milligram per deciliter of per day of prednisolone, with or without a short taper, and it is like also alternative 3 to 7 days course of oral methylprednisolone administered. These basic stuffs we know. We can also go for plasma exchange, which is recommended if there is a poor glucocorticoid response. Okay, and this is administered daily or every alternate day for like 3 to 7 times. Okay, now the differential diagnosis.